This is Selma Schimmel in Chicago at the annual ASCO meeting for the group room, and we're very happy to sit with you, Dr. Clifford Hudis, Chief of the Breast Cancer Medicine Division at Memorial Sloan-Kettering Cancer Center in New York City. Hi, Dr. Hudis.
Hi.
Thanks for being here.
It's a pleasure.
What's happening at ASCO 2012?
This was presented here at the meeting for the first time, but you're going to hear more and more about it. The concept of the Rapid Learning System, RLS. This is something that the Institute of Medicine has asked for. This is something that everybody sort of sees coming. This is the merger of our electronic medical records with the kind of data mining and informatics tools that are really pretty commonplace in other industries, not medicine. Financial industry, search, everywhere else. So I'll start with something simple. If I buy myself a late model American automobile of any kind, and I have it serviced in New York City, and then I drive it across the United States, by the time I get to Los Angeles, any company garage and most non-company garages can plug in a sensor and they can glean from that car its service history, when I changed the oil, what, even possibly how I drove it. But you as a patient cannot demonstrate any interoperability like that. In fact, you can be treated on the west side of a major avenue in New York City and cross in a tunnel to an adjoining hospital that's physically attached, and your records can't go with you. This is an astonishing failure of informatics on our part. It's an astonishing failure of centralized rulemaking and identification of commons and standards. So imagine a world where, in fact, those barriers are either fixed centrally with rules, or using the latest informatics tools, it no longer matters which of the myriad systems you are using, but you can crawl through that data. And I imagine a world where that patient you described goes to her doctor, and she is just entering orders on the electronic medical record that is in her local office, and when she goes to write a chemotherapy order for her patient with non-small cell lung cancer, the computer simply says, pop up, gee, I noticed that your patient hasn't had sequencing. And that's standard. So the computer helps the doctor at point of care deliver better quality of care, independent of participation in research. That's where we're headed.
Sometimes it's actually the patient that needs to be the provider of their information. And when I talk to patients and find out they don't have their operative report, they don't have their path report, we need to start training patients as consumers.
But I actually think it's all kind of sad because A, the material is theirs.
That's correct.
B, they shouldn't have to do this. It really shouldn't be so complicated. There's really no reason for it.
I think that there may be some issue coming from, again, a culture where physicians held the information. That there's a mental shift in what it means to let the consumer hold the information, and also if you haven't had a chance to talk to your patient about maybe a difficult report, perhaps you might want a chance to discuss it with your patient before the patient simply reads it.
So we've been dealing with that. We have a patient portal, as I know you know, and you can look up your laboratory results and you can look up your imaging results. And I caution patients about that because it means that on Friday night at 8 o'clock, you might stumble on to a result that does require explanation. And you have to be very certain as a patient that you're going to be comfortable on Friday night dealing with that without the help of a doctor before you go looking. That said, fundamentally, I agree with the idea that the choice is the patient's.
Yes.
If you want to spend the weekend sleepless because you can't talk about this till Monday, I understand that. That's a choice to make, and I can't always help with every single thing. Your doctor is not available 24/7, no matter how superhuman they may be. But ultimately, I think we'll get over that because the greater good is the transparency. And I think it's really wonderful. Now, I will say it does cause a fair bit of anxiety, and ultimately we're dealing with paternalism versus autonomy, because I will have patients call me up very concerned because their bicarb on an electrolyte test, is a point over what we call normal. And there's just nothing to discuss there, right?
Right.
But they're worried about it, and so
Well, when you see
says
the
abnormal.
high-low, right, exactly.
Right, and it's a shame for anybody to lose, even a
Sleep over
moment's
that, right,
a moment
exactly.
of comfort over such a thing. But it does happen, unfortunately, and that's the price we pay. But my issue is, and I want to be clear about this, is not so much about your ownership of your data, which I don't think is a debatable point. I think we, societally, have failed in the sense that none of this should require this legwork on the part of the patient. You should be able to walk into any doctor's office, provide a secret code, let's say, and let the doctor see your records without any special effort, just using a browser. And by the way, that's what you do with Gmail. Any computer in the country, put in the Gmail address, up comes your mail. You don't have to worry about which browser or which operating system or which internet portal your computer's connected to. For that matter, you hardly need to worry about what device you're using.
Why do you think it has taken so long to bring
Well,
this
that's a very complicated question, and I can't answer it. I'll only point out that because it's taken so long and because the problem must be addressed in terms of electronics, if anything, we're in a worse position now because we have this kind of Tower of Babel of electronics.
Thank you. Dr. Clifford Hudis, Chief Breast Cancer Medicine, Memorial Sloan-Kettering Cancer Center in New York City, and President-elect 2014.
Thank you very much.
Thank you very much.